In this chapter, we will be looking at the injuries that can occur at the knee joint. The knee is a hinge joint, however, it has 6 degrees of freedom. It allows for flexion, extension, medial and lateral translation, superior and inferior translation, and anterior and posterior translation, varus and valgus rotation, and an axial rotation. This is uncommon for a hinge joint. For instance, when comparing to the elbow, another hinge joint, it only has 2 degrees of freedom. It is important to understand that stability comes from the ligaments of the knee, which attempts to only allow the knee to perform 2 motions at a time. Like with every assessment, the history can be the most important part when trying to provide a differential diagnosis. These are some of the questions to ask when performing the history part of the evaluation. With the knee, similar to the shoulder, the mechanism of injury is extremely important in isolating the different ligaments and structures that can be compromised, especially if the athlete suffers from an effusion. Chronic injury of the knee are very common in athletics and can present with many different signs and symptoms, requiring your history to be very involved. Understanding how to describe the different types of pain is helpful in your history. You always want to ask in the knee evaluation about range of motion ability and walking upstairs. If the athlete can, demonstrating how to walk, squat, and go up and down stairs is vital to your assessment. Many individuals are born with different biomechanical differences that exacerbate the symptoms that they are feeling. It is also important to assess ankle and hip range of motion and strength, which could be adding additional stress of the knee and contributing to the issue. Bony structures include the different areas of patella, fibular head, tibia, the tibial spine, etc. Soft tissues include the MCL, LCL, joint line, menisci, patellar tendons, etc. The Lachman test and anterior/posterior drawer test are the most accurate special tests in indicating damage to the ACL. Both tests, when performed, are actively translating the tibia anteriorly on the femur. You always want to perform a special test bilaterally, as some people have general ligament laxity. In these tests, as you translate the tibia, you are trying to feel resistance or an end feel, where you cannot go any further. This indicates that the ACL is still providing tension. However, it does not rule out the presence of a partial tear. Apley's test is used to indicate a meniscus tear. There are many more tests that can be performed to assess the different structures of the knee. However, it is important to understand that special tests are not able to diagnose a tear to these structures. MRI is needed to confirm your findings. Laxity in a knee joint decreases the stability of the joint. When we talk about tibial translation, we are describing the movement of the tibia on the femur, which is anterior. If you wanted to describe the femur movement on the tibia plateau, it would be considered femur translation or posterior translation of the femur. The valgus and varus stress tests simply move load-bearing axis of the knee joint to either the outside structures, the LCL, or the inside structures, the MCL. The first video will demonstrate a physician's knee exam, simulating the typical 10-minute exam that a physician would do if you saw them in office for an evaluation. The second video demonstrates the different special tests and will show you a positive test. Disclaimer, if you are queasy, I would recommend not watching the second video, but you still need to understand the mechanism of the special tests. The MCL can be sprained and has similar grading to the sprains of the ankle ligaments that we discussed previously in class. The MCL sprains due to a valgus force at the knee. This is mostly due to a direct blow to the knee, causing it to cave inward, or due to an external twist of the joint. The signs of each grade of sprain are shown above. Something to think about with a moderate to severe sprain of the MCL is that the fibers attach to the medial meniscus, making it intracapsular, so it will present mostly with a joint infusion rather than localized swelling. The care of the MCL is similar to how you care for most ligament sprains. Pain management techniques in the first 24 to 72 hours and immobilize if needed. Then you progress through your rehab stages, isometrics to strength and stability exercises to cardio and isokinetics, sport-specific exercises, and plyometrics. Once the individual can perform sport-specific drills, a functional hinge brace can be worn for additional protection until the athlete has normal range of motion, strength, power, flexibility, and endurance to progress out of the brace and return to activity. An LCL sprain is caused by a varus force with a medial rotation of the tibia. Unlike a sprain to the MCL, if an LCL sprain occurs, it will have a localized effusion in the surrounding area rather than a full knee effusion because the LCL is completely extracapsular. The LCL and MCL have the same rehab protocol. An ACL tear occurs with hyperextension and internal rotation, often happening during a pivot or cutting motion in sport. ACL tearing is 2 to 8 times more common in females than males due to the different landing mechanics, with females landing with more knee extension, which puts more stress on the ligament. ACL sprains have been deeply researched, breaking down in the stress and factors such as femoral notch, differences in ACL size, and laxity and malalignments. One specific malalignment is the Q angle, which is the biggest malalignment that can predispose an individual to an ACL sprain. The Q angle is the angle of the quadriceps muscle and the patellar tendon. The more that this angle is increased, the individual will present as knock-kneed, which can cause increased stress on the ACL as well as cause many chronic patellar injuries. This injury is mostly acute in nature, with a pop being heard and intense immediate pain. The ACL rehab process is extensive with surgery and rehab. Now, the likelihood of re-tearing an ACL is pretty high, even with no issues in rehab. The rate of re-tear in sport is about 55%. ACL tears are more common in sports that require quick deceleration, such as soccer, lacrosse, football, volleyball, etc., with women's soccer statistically having the most ACL injuries according to the NCAA. Disclaimer: the video in the slideshow shows athletes tearing their ACL to show mechanism of injury. Do not watch if you are not good with watching injuries as they happen. PCL tears are not very common in sport. However, it occurs most commonly by falling on a flexed knee, which causes the posterior translation of the tibia on the femur. PCL tears can have surgical or non-surgical care depending on the grade of tear and sport. Meniscus injuries are very common in a wide variety of sports, between the jumping stress that can occur on the meniscus as well as the repetitive shearing that can be caused by running in sport. The medial meniscus is the more commonly torn meniscus because it has that attachment on the MCL. It is common for the ACL, MCL, and medial meniscus to be injured together, and we refer to this as the unhappy triad. These structures are commonly torn by the same mechanism of injury. Diagnosing a meniscus tear is very difficult without imaging, but it is very common to have joint effusion and loss of motion. Meniscus tears usually follow the same rehab protocol as an ACL tear. There are 2 types of meniscus surgeries. One is a repair where they perform a scope, clean up the torn frayed fibers, and suture down what is needed, and another is a meniscectomy, where they remove the torn part of the meniscus. Inflammation of the bursa is very common with repetitive stress on the patella, especially when the patella does not track correctly in the groove. The swelling will be soft and easy to move rather than an effusion of the joint. It will also appear higher than the knee. Steroids and NSAIDs can be used to help decrease the swelling. However, sometimes they need to be aspirated. The video above shows a knee aspiration. If you do not like needles, do not watch this video. IT band syndrome is a chronic injury very common in runners, which occurs due to the friction of Gertie's tubercle where the IT band snaps over it during knee flexion and extension. The IT band is like a strong, thick rubber band that has 3 muscles that attach to it: the glute med, glute max, and the TFL. When these muscles are tight, it can cause more tension on the IT band, causing inflammation to occur on the insertion. A patella fracture is not super common in sports, but it is caused by extreme contraction of the quadriceps and patellar tendon, falling on the knee, jumping, and running. It can sometimes present with a deformity, but swelling can make this difficult to visualize. Quad tendon and patellar tendons can also be torn with this fracture. Normally can be treated with immobilization for 2 to 3 months rather than surgery. Deceleration and valgus force can cause the patella to sublux or dislocate. The quadriceps muscle pulls the patella out of alignment in this situation, causing the patella to dislocate superiorly and laterally. Like with any dislocation, in the first injury, you should always assume a fracture is present. Once the injury occurs, it is likely that it can happen again. A patella dislocation can be reduced with the knee being brought into extension with a force pushing the patella towards the knee. Refer to the physician to assess for the ligaments of the patella to ensure that a tear hasn't occurred.